Good morning to everyone. I'm Dr. Khor. I would like to thank the organizing committee for the invite and everybody for joining us this morning. I'm tasked to talk to you about, Doctor, I think I have male menopause. I will start off by sharing a case of Mr. Low. Mr. Low is a 47-year-old executive, married with 2 children. He complained of erectile dysfunction for the past 5 months. He had difficulty to maintain erection. His erection hardness score is grade 2. He also had low energy level with reduced libido, and otherwise no medical illness. He is slightly overweight, like our Malaysian man. His prostate. This is often encountered in the urology clinic. The prevalence of hypogonadism, based on the population baseline, is between 2 to 12% for men aged 70 years old. This, however, increases with age, obesity, type 2 diabetes, and chronic illness. Men generally has a declining level of testosterone, both total and free testosterone, with aging, as shown in the graph. Above 40 years old, testosterone levels start to drop. This might be reflected by the incidence of comorbidity with aging rather than age itself. In type 2 diabetes, up to 43% of the patient has low testosterone. This is due to impaired hypothalamus pituitary function, and they do tend to have low normal luteinizing hormone as well. Similarly, in obesity, they have even a higher association with low testosterone. So, what is male menopause? Some call it andropause, late onset hypogonadism, low testosterone, testosterone deficiency. However, all this should be avoided. Male menopause or andropause denotes uncertainty with age, similar to menopause in women, but this is not true. Not all men develop hypogonadism. The term late onset hypogonadism separates it from congenital or prepubertal hypogonadism, but some patients develop it at an earlier age. Low testosterone and testosterone deficiency only denotes biochemical level. The term should be hypogonadism. And the definition of low testosterone is low level of testosterone on 2 occasions with fasting level, accompanied by symptoms and signs of hypogonadism. Let's look at the symptoms of hypogonadism. The most accurate symptoms to assess hypogonadism are reduced libido, erectile dysfunction, and reduced spontaneous erection, as highlighted. But there are other signs and symptoms as well. They might also have physical symptoms like fatigue and weakness. Not uncommon, men with hypogonadism have low level energy as well as mood. The other symptoms are similar to patients with dementia, however. Obesity, especially abdominal obesity and diabetes, increases the chance of hypogonadism as well. There are questionnaires available, but unlike IPSS for BPH or IIEF for erectile dysfunction, I rarely use it. I find that asking them the key sexual, physical, and psychological symptoms is more direct and useful. Biochemically, 2 levels of morning total testosterone is required, preferably in fasting. The diurnal testosterone level is the highest from 7 to 11 a.m. Thus, testosterone level should be taken before 11 a.m. for this reason. 98% of testosterone in our body is bound. Only the free testosterone and albumin bound can be utilized by our body. These are called bioavailable testosterone. Certain conditions of medication can increase the sex hormone binding globulin level. If in doubt, the bioavailable testosterone can be calculated. Total testosterone level below 12 nanomole per liter or free testosterone level below 220 picomole per liter is defined as low. The level in which testosterone replacement therapy is beneficial is 12 nanomole per liter. More pronounced if it is less than 8 millimole per liter. Bioavailable testosterone is free testosterone plus albumin-bound testosterone, excluding sex hormone-bound globulin-bound testosterone. If you look at the right side of the screen, is a screenshot of an online calculator to estimate the free testosterone and bioavailable testosterone. I key in the normal abdomen level, which is 40, and the testosterone level of 12, and the sex hormone binding globulin of around 96. So if you look at the level, even though the normal level of testosterone is put in, you can still see that the free testosterone as well as the bioavailable testosterone level is still low. The level of testosterone needs to be repeated, however. Normally, the luteinizing hormone and the prolactin is taken together to rule out secondary hypogonadism causes. In anticipation to initiate testosterone replacement therapy, hematocrit, sugar lipid profile, and PSA is also measured. Imaging in the form of MRI is needed if pituitary tumor is affected. Let's come back to our story, Mr. Low. Mr. Low hemoglobin is normal with a hematocrit of 4.9. His lipid profile is slightly elevated. Serum testosterone taken in the morning is 8.03, which is low. PSA level is normal. So repeat the blood test 2 weeks later. His serum testosterone is still low at 7.9. His LH and prolactin is normal. So we discussed the testosterone replacement therapy benefits and the side effects, and the types of modality available, injectables or transdermal gel. So what are the benefits of testosterone replacement therapy? Testosterone replacement therapy improves libido as early as 3 weeks after initiation of treatment. Erection might take longer, so normally it takes around 6 months. Patients can observe increase in their muscle mass with exercise. Testosterone also contributes to preservation of bone mass. There's a recent publication to suggest its benefit in early diabetes. I will share this in the next slide. This is a recent study published in The Lancet early this year. Patients with early diabetes or impaired OGTT with low testosterone were randomized to lifestyle changes with or without testosterone treatment for 2 years. It showed a reduction in newly diagnosed diabetes in patients with added testosterone treatment. There's a few contraindications, however. One of it is the metastatic prostate cancer, as testosterone is thought to drive the tumor cells. In male breast cancer, testosterone are converted to estradiol by peripheral aromatization. If the hematocrit is higher than 54%, as testosterone does elevate hemoglobin. Rarely venesection is needed. We just need to prolong the interval between treatment. Patients with severe chronic heart failure should also be excluded from testosterone replacement therapy due to possibility of fluid retention and worsening failure symptoms. If your patient have desire to have urine, so this should be avoided because it does suppress the hypothalamus pituitary gonadal axis and does cause a reduction in the FSH as well as LH, lowering the sperm level. Obviously, if your patient is a professional athlete, anabolic steroids should be avoided. So I discussed with Mr. Low and he has opted for IM testosterone. There are various forms of testosterone, but basically the formulation differs only in their half-lives. Libido is given again at 3 weeks and followed by a 12-weekly injection, while plastonon or testosterone is given every 3 weeks. Mr. Low was happy with the symptoms improvement on follow-up. The total testosterone improved to 13.1 nanomole per liter at 3 months, and this reflects the testosterone trough level. This is important so that you can adjust the interval of injection accordingly. If below the target level, then we have to shorten the interval. So these are the list of types of testosterone replacement therapy. I normally prefer injection or gel. Gel has the advantage of stopping if patient develops side effect as compared to injection. Oral preparation, however, the gut absorption is less predictable. It has to be taken with high fat to enable gut lymphatic absorption, bypassing the liver to prevent toxicity. Transdermal patches can cause skin rashes. Subcutaneous pellet can last up to 6 months, but run the risk of extrusion with the thin active nail. And the buccal mucosa can cause gums. Let's compare between injection and transdermal gel. Injection is effective, can cause polycythemia, However, that pain is injected inside. This is due to the oil used. In libido, we use castor oil and Saturnon is peanut oil. So normally patients develop pain immediately after injection and it gets better after 4 days. There's a risk of oil embolism, so we need to observe the patient post-injection for sureness of breath, and they will need clinic visit for injection. So the difference between libido and Saturnon is that libido has a longer half-life, therefore it has less fluctuation. It's given every 12 weekly. However, it's more expensive than Saturnon. While the transdermal gel is effective, it's convenient to apply, it has less skin irritation versus the patch. However, you have to be worried about transference, so be careful around pregnant ladies as well as children, and effective as well. So the monitoring is straightforward. Assessing efficacy of treatment and complication like ELAP and obstructive sleep apnea. PDE5 inhibitor might be added for erectile dysfunction if it doesn't improve. Only mild ED improve with testosterone replacement therapy alone. It might take up to 6 months for noticeable improvement in the erection height. Hematocrit testosterone and PSA level is taken at 3, 6, 12 months and annually after that. So ladies and gentlemen, the whole point, hypogonadism is prevalent in aging male obesity and chronic illness, especially in patients with type 2 diabetes. The diagnosis is straightforward. So the benefit of testosterone replacement therapy is beyond sexual symptoms. There are multiple ways to give testosterone. Basically, the preferred way are injection and gel. And the monitoring is simple with acceptable. Okay, thank you. I'll be happy to answer any question in the Q&A session later.